Good evening, everyone. This month happens to be the Myeloma Awareness Month, as we are all aware. And the March, which is a Multiple Myeloma Awareness Month, is a time to raise awareness about the myeloma and support those affected by it. There are various international organizations who have been working on it. But as Indian Myeloma Academic Group, we have been doing our bit to raise awareness. And when we say raise awareness, it's also to empower patients, advocate for research, and support the various families and the caregivers of myeloma to fight this particular disease, which is not easy, but for sure a complex disease. So today we are going to have the Journal Club and a Journal Scan, which is a webinar series which is held on every fourth Thursday of every month. And till now, we have had 29 journal clubs. We started in September 2022, covering around 20 institutes wherein they have presented the articles in this particular event, with 14 international faculty who have taken part in this particular journal clubs. We total have till now 2,308 participants from different parts of the country as part of these educational events, and approximately 108 international participants, which includes particularly students from Southeast Asian countries, particularly Pakistan, Bangladesh, Nepal, and Sri Lanka, and also from sub-Saharan African countries who have been part of these journal clubs. So this is no more national, but definitely an international event, both with international faculty on board and international participants on board. Taking this further, this month, we are planning to discuss two very important studies related to monoclonal gammopathies. And to present the journal club, we have Dr. M. Vinodini, who happens to be an associate professor at All India Institute of Medical Sciences, BB Nagar, Hyderabad. So she is a faculty there. She completed her fellowship or DM from JIPMER, and thereafter she has joined as a faculty in Department of Hematology and Medical Oncology at AIIMS Hyderabad or AIIMS BB Nagar, Hyderabad. For quiz, we have a new entrant today as a quiz master. We have Dr. Karan Sood from Wardha, who is going to hold the quiz. And we are really very happy and proud to say that we have got two eminent figures today, Dr. Vincent Rajkumar and Dr. David Murray, who are going to be our international discussants. Just to introduce Dr. Murray, I had an opportunity of following him at Mayo Clinic. He heads the Department of Immunology at Mayo Clinic and Mayo Lab in Rochester, and a great figure in the field of myeloma, wherein he is the man behind the MASFIX, which all of us keep discussing in various parts of the world. So he's the one who actually developed that, got it published, and is advocating mass spectrometry as the routine testing for the screening as well as for monitoring myeloma. So we are very thankful to Dr. David for taking out his time early in the morning and joining us for this journal club. So without further ado, I would request Dr. Vinodini to kindly present the journal club article.
Good evening, everyone. At the outset, I would like to thank Indian Myeloma Academic Group, Dr. Uday sir, and Dr. Sumit for giving me an opportunity to present the journal club, which was comparison of progression risk of monoclonal gammopathy of undetermined significance by the method of detection, published in the Journal of Blood in January 2025. I would like to begin my talk with a brief introduction on monoclonal gammopathy of undetermined significance. So MGUS, which was first described in 1960 by Waldenstrom as essential hyperglobalinemia or benign monoclonal gammopathy, but he firmly believed that it was unrelated to myeloma at that time. However, later on in 1978, Robert Kyle coined the current term as monoclonal gammopathy of undetermined significance, and it is a clinically asymptomatic pre-malignant disorder, and it is a precursor for myeloma, Waldenstrom, as well as amyloidosis, and defined by the presence of monoclonal protein less than 3 grams per deciliter, less than 10% plasma cells in the bone marrow, and absence of end organ damage. The risk of progression in persons aged above 50 years, 70 years, and above 85 years are approximately 3.2%, 5.3%, and 7.5% respectively. The prevalence being 4.2%, of which 0.8% was light chain MGUS. Three distinct subtypes of MGUS were classified based upon the M protein isotype as IgM MGUS, non-IgM MGUS, which includes IgG, IgA, as well as IgD, as well as light chain MGUS. The risk of progression to myeloma, Waldenstrom's macroglobulinemia, AL amyloidosis, or lymphoproliferative disorder is approximately 1% per year for IgM MGUS, 0.5% for non-IgM MGUS, and 0.3% for light chain MGUS. This is a landmark paper published by Dr. Robert Keil in American Journal of Medicine. And this study cohort comprised 1395 persons with MGUS who are diagnosed at the Mayo Clinic from 1960 through 1994, who resided in the 11 counties of southeastern Minnesota. And patients with light chain MGUS were excluded from the study because this entity was not defined at the inception of the study. The primary endpoint was progression to myeloma or another plasma cell disorder. So out of 1384 patients who were followed up for a median of 15.4 years, 70% have died. During the follow-up, myeloma, lymphoma, primary amyloidosis, macroglobulinemia, CLL, or plasmacytoma, they developed in around 8%. So the cumulative probability of progression to one of those disorders was 12% at 10 years, 20%, 21% approximately at 20 years, and 26% at 25 years. And the overall risk of progression was 1% per year. This shows the three major risk factors for the progression of MGUS or serum monoclonal protein less than 1.5 grams per deciliter, non-IgG MGUS, as well as abnormal serum free light chain ratio. Based upon the Mayo Clinic's risk stratification model, presence of all three risk factors is defined as high risk MGUS. High intermediate MGUS is if any two risk factors. Low intermediate MGUS is one of the risk factor. And absence of all three risk factors is classified as low risk. The risk of progression to a lymphoplasmacytic neoplasm at 20 years when 1, 2, or 3 risk factors are present is 5%, 21%, and 58%. The risk of progression among patients with IgM MGUS is 2% per year in the first 10 years after diagnosis, and thereafter it is 1% per year. Non-IgM MGUS is associated with the risk of progression at the rate of only 0.5 to 1% per year. Both IgM as well as non-IgM can progress to AL amyloidosis, and there is being 1% over 35 years of follow-up. Light chain can progress to light chain myeloma as well as AL amyloidosis, with the risk being 0.3% per year. Recommendations from the IMWG suggest 6 monthly follow-up for low-risk patients, and then every 2 to 3 years if the disease is stable. Whereas for high-risk patients, the follow-up should be done annually after an initial 6-month follow-up from diagnosis. This shows the monoclonal gammopathy of undetermined significance consistently precedes multiple myeloma. Here again, the M protein concentration levels year by year prior to multiple myeloma diagnosis is being shown. In half of the study population, the M protein concentration levels showed a steady increase year by year prior to.
Yeah, Nirav, can you just get the screen cleared because we are not able to read anything. So can you just project it properly? Yes, this is better.
Prevalence of MGUS and lifelong.
The prior
knowledge of MGUS, we have a better survival compared to of optimal follow-up of MGUS on early diagnosis and prevention of myeloma-related complications. So optimal follow-up resulted in a statistically shorter interval time from diagnosis to the diagnosis of symptomatic myeloma for patients in the optimally followed-up category, which is shown in the red line, compared with suboptimally followed-up patients shown in the blue line. Among all patients of southeastern Minnesota who have who are seen at Mayo Clinic between 1973 to 2004, and for whom MGUS had progressed to multiple myeloma, 69% had optimal follow-up of MGUS, for whom multiple myeloma was diagnosed in 16% on serial follow-up, whereas it was diagnosed in 45% only after serious myeloma-related complications. And prior multiple myeloma patients with the prior knowledge of MGUS, they have a better survival compared to patients without prior knowledge of MGUS. So they had those who had prior knowledge of MGUS had a significantly better survival of 2.8 years median than those without prior knowledge of MGUS, where the median survival was only 2.1 years. And risk stratification for MGUS, patients with the preceding diagnosis of MGUS had a lower incidence of major complications such as spinal cord compression, renal replacement therapy, fractures, or hypercalcemia when progressing to MGUS-associated malignancy than patients with no prior clinically detected MGUS. The comorbidities, infections, inflammation, immunological disorders involving immune activation or dysregulation, they are implicated on the progression to myeloma in clinically diagnosed MGUS than screen cohort. The risk stratification score comprising monoclonal protein more than 1.5 gram per deciliter, SFLC ratio less than 0.26 or more than 1.65, non-IgG MGUS and immunoparesis, they were established in clinically detected cases, but they were not validated in the screen cohort. Although the idea of screening for MCUS may be compelling, there are some downsides which need to be considered. There are no modifiable risk factors to decrease the progression risk or curative interventions to offer once the diagnosis of MCUS is established. A diagnosis of MCUS can lead to significant mental distress for patients, and routine screening could further strain the already overburdened healthcare system because of the high prevalence of MCUS and lifelong clinical and laboratory follow-up evaluations required. Clinical MCUS is usually diagnosed in patients with comorbidities which involve immune activation and dysregulation, which have been associated with a higher risk of progression. Hence, we presume that clinical MCUS is worse with respect to progression risk compared to screened MCUS cohort. So the aims of the study were to compare the progression risk between screened versus clinical MCUS cohort to assess whether MCUS detection method modified the predictive value of established clinical risk for progression. So coming to the methodology, the study cohort comprised 350 out of 379 patients aged above 50 years who were screened for heavy chain MCUS as part of the population-based Olmsted County study conducted between 1995 to 2003. As part of this screening study, the primary care providers of the people diagnosed with MCUS were notified. The cleaning cohort comprised 1,148 out of 1,348 patients who were derived from 11 counties in southeastern Minnesota and had MCUS detected during the clinical evaluation between 1st of January 1960 to 31st of December 1994. The cryopreserved serum samples from patients with MCUS diagnosed during routine screening and those during clinical evaluation with the available stored samples from the date that MCUS was first identified were tested with the serum free light chain assay. So it was done on cryopreserved sample as they were not available in the era when clinical MCUS was diagnosed, which emphasizes the potential benefits of biobanking samples in the current study. So statistical methods, the prospective data and progression and outcome were obtained from Mayo Clinic Dysproteinemia Registry on 1st of March 2023 after ethical approval. Categorical variables were evaluated using chi-square test and continuous variables using two sample t-test in both the screen as well as clinical cohort. Cumulative incidence for progression accounting for death was assessed using Kaplan-Meier method. Cox proportional hazard model was tested to identify the strength of association between the individual risk factor as well as the composite risk score and the progression risk. Likelihood ratio was generated to test the potential effect modification by MCUS detection method on established risk factors in both the screened as well as clinical cohort. P-value less than 0.05 was considered significant. The results of the study. So it shows the baseline characteristics of the screened as well as the clinical cohort. The median age and diagnosis was similar between patients in the screened as well as in the clinical cohort. The clinical cohort had a higher proportion of patients with a monoclonal protein above 1.5 grams per deciliter, abnormal free light chain ratio, as well as immunoparesis, but similar proportions of IgG, similar proportion of isotype, which is IgG, which were more common. So immunoparesis is defined as decrease in at least one of the uninvolved immunoglobulin isotypes below the lower limit of normal, has also been established as a risk factor for MCUS progression in the current study. So progression events in the screened and clinical cohort. During the study follow-up, 42 patients in the screen, 42 people in the screen and 149 patients in the clinical cohort progressed to multiple myeloma, lymphoproliferative disorder, or a related plasma cell disorder. Myeloma was the most common progression event in 74% of the screened MCUS and 62% of the clinical MCUS, followed by amyloidosis and lymphoma. This shows the follow-up and progression analysis. The median follow-up from diagnosis was 26 years in the screening cohort and 40 years in the clinical cohort. As of March 2023, 72% of screened cohort and 86% of the clinical cohort had died without progression, and 17% of screened and 3% of the clinical cohort were still alive without progression. Accounting for death as a competing risk, cumulative incidence of progression at 20 years was similar in the screened versus 9.5% in the clinical cohort, even when they were stratified by age, gender, or the baseline MCUS risk score. So cumulative incidence of progression accounting for competing risk was similar in the screened as well as the clinical cohort. Overall risk of progression was also similar at 0.9 in screened versus one of those with the clinically detected MCUS experienced disease progression for every 100% years of follow-up in the clinical cohort. No significant difference in the cumulative incidence of progression to myeloma specifically between both the cohorts detected through routine screening. So this shows the Kaplan-Meier estimates of progression. It was shown in green color. Given that the progression risk was relatively low among patients with MCUS, most of the patients in both the cohorts, they died during study follow-up as shown in the red lines. Therefore, the cumulative incidence function was used to assess the cumulative incidence of progression accounting for death as competing risk, which was shown in blue color. Accounting for death as competing risk, progression at 20 years was similar among patients in both screened as well as in the clinical cohort, even when they were stratified by gender, age, as well as baseline MGUS risk score. So this shows the forest plot of progression rate per 100% years in the screen cohort as stratified by MGUS risk factors. So the risk of progression was similar in the both screened as well as in the clinical cohort, with each individual risk factors such as M protein concentration, FLC ratio abnormality, immunoparesis, or the composite risk score. Only patients with IgA MGUS who were diagnosed during screening had a higher progression risk compared with patients with clinically detected IgA MGUS. So this again shows the forest plot of progression rate per 100% years in the clinical cohort as well as by clinically relevant subgroups, which again depicts similar progression risk in both screened as well as clinical cohort, with individual risk factors such as M protein concentration, FLC ratio, immunoparesis, as well as a composite risk score. So this shows the additional Cox models which were generated representing the interaction between the type of MGUS detection method and established MGUS risk factors, including the composite risk score to assess the effect of potential modification due to the MGUS detection method. So this shows the type of MGUS detection method did not significantly add any information to the model that estimated the association between established MGUS risk factors and the progression risk. So key factors for progression, the MGUS detection method, whether it is screening or clinical, did not modify the association of risk of progression with M protein concentration, FLC abnormality, immunoparesis, or the composite risk score. However, patients with IgA MGUS who were diagnosed through screening had a higher progression risk compared with patients with clinically detected MGUS, which also corresponded to a higher risk of progression for IgA MGUS relative to IgG MGUS in the screening cohort, the hazard ratio being 4.3 in the screen cohort compared to 1.3 is the hazard ratio in the clinical cohort after adjusting for baseline FLC ratio and M protein concentration. So the method of MGUS detection method did not add any predictive value to establish progression risk score. So to compare with the various literature, our results are concordant with other data which supported IgA isotype high monoclonal protein immunoparesis as well as abnormal FLC ratio. And this is a first population-based study, whereas others were not population-based study, and the prevalence of MGUS is a bit lower compared to the current study. So, whereas the current study included patients only from European ancestry, the results from the PROMISE study showed the prevalence or screening of MGUS is higher in individuals with the Black African Americans and who have a first-degree relative with a hematological malignancy, and they may benefit from precision screening approaches to allow for early detection and clinical intervention. The current study is also concordant with the other study, that is the characteristics and risk factors of MGUS in the multi-ethnic cohort study, where again the IgG isotype was the commonest compared to IgA isotype. So serum free light chain ratio is an independent risk factor for progression. The risk of progression of MGUS to myeloma related disorder using a risk stratification model, which has been already described, which incorporates FLC ratio as well as the size and the type of M protein. This shows the presence of all three risk factors. The second curve shows the presence of two risk factors, and the third shows the presence of one risk factor, and the last shows the presence of one risk factor. And patients with high intermediate with any two risk factors, they had a relative risk of progression of 10.1%. Who had all three risk factors, again, they had a higher risk of relative risk of 20.8%. And the absolute risk of progression at 20 years, accounting for death being 18%. Whereas with those who had all three risk factors, they had a risk of 27% at 20 years. So this is a primary endpoint of the landmark study where the progression rate among the cohort of 1384 patients with a median follow-up of 34.8 years was studied. During this time, 74% have died. Of the 84 patients who were still alive, 5 had disease progression and 79 did not progress. The cumulative incidence of progression of MGUS with death accounted for as a competing risk. The risk of progression without accounting for death due to competing causes was 10% at 10 years, 18% at 20 years for non-IgM MGUS, whereas among patients with IgM MGUS, the risk of progression at 20 years was 55%. This shows the observed survival rate in the cohort versus the expected survival rate in the control population. patients with MGUS had shorter survival than which was expected in the control population of Minnesota residents with a matched age and gender. The median being 8.1 years, whereas the control population had 12.4 years. This is a prevalence of MGUS is high in the iSTOP multiple myeloma study, but the prevalence of IgA MGUS does not increase with age in the way other immunoglobulin subtypes study in the immunoglobulin subtypes do, which means that immunosenescence involves increased amount of overall IgA secretion, which has been observed in this iSTOP multiple myeloma study, and it is considered to it is important to consider because IgA M protein, they are more often transient, they arise less frequently in later on life, and they are associated with a shorter lifespan. That is likely the possibility that the prevalence of IgA MGUS did not increase with the age in the iSTOP multiple myeloma study. Also, it showed that it negates the previously reported biological correlation between autoimmune disease, MGUS, light chain MGUS, and shows that autoimmune diseases, they are not associated with MGUS. And the history of prior cancer was associated with the progression of MGUS, except myeloid malignancy, which were associated with a lower risk of progression. And those who had prior cancer is not a significant etiological factor in plasma cell disorder, and it does not warrant further MGUS screening or differential management of MGUS. So this is a larger screening study of MGUS to date, which is the iSTOP multiple myeloma study, which is highly representative of the general population, which stated that there were no statistically significant difference in the prevalence with respect to individual risk factors, as well as in the mean number of risk factors of progression, except that the odds ratio of M protein above 1.5 gram is associated with the risk of 1.92, and the mean number of risk factors of progression being 0.04, which is discordant with the current study. So again, a systematic review finding on association between patient characteristics and progression to myeloma among patients with MGUS. It showed older age, female gender, and obesity were implicated in MGUS myeloma progression, whereas our study did not take obesity into account. So where are we standing now with regard to screening for MGUS? Are we towards tailored screening in MGUS? So this is a IMWG recommendations regarding mass spectrometry for the evaluation of M proteins in myeloma as well as related disorder. High sensitivity mass spectrometry assays, they are available to detect the monoclonal immunoglobulins. To better assess the prevalence of MGUS, around 300 patients who were diagnosed with MGUS and related gammopathy who had a prior negative workup as part of the Olmsted County study, they were tested with two mass spectrometry detection methods. One is MALDI-TOF as well as monoclonal immunoglobulin rapid accurate mass measurement. Along with the traditional immunofixation, they were performed on the Olmsted County cohort baseline and MGUS diagnostic serum samples. Using this sensitive technique, a higher prevalence of 5.1% was noted, which is the most accurate prevalent estimate of MGUS so far. And it also endorses the use of mass spectrometry along with immunofixation in distinguishing therapeutic antibodies from endogenous M proteins. And it also states that mass spectrometry methods along with conventional immunofixation may lead to lower rates of CR, and therefore cross comparison of CR rates in trials done in different time periods is not recommended. So coming to the study highlights, this is the first study to compare the outcome of MGUS in screened versus clinical cohort. Robust size and long-term follow-up allowed for sufficient detection of progression, though the period of detection for screen being 1995 to 2003 and clinical being 1960 to 1995, which resulted in differential length of follow-up, detection, management. The outcomes were comparable in both the arms. Though patients with missing data, particularly SFLC values and immunoparesis, would have been excluded from the model, the bias due to missing data was very less. Screen patients undergoing routine monitoring may have earlier identification of signs and symptoms, thereby reducing the rate of serious myeloma-related complications, morbidity, as well as healthcare resource use related to disease progression. Coming to the limitations, this is a study which evaluated only heavy chain MGUS, so results were not generalizable to light chain only MGUS or those which were detected using highly sensitive techniques such as MALDI-TOF mass spectrometry. And given the differential filtration of light chain in renal failure, some patients with CKD may have been misclassified as having abnormal FLC ratio, thereby affecting clinically detected MGUS more than screened cohort because renal function may have prompted a workup for plasma cell disorder. And the study, the patient participants were mainly of European ancestry, so results need to be validated in other ethnic groups. And data regarding the clinical consequences and symptom severity and disease progression were not available, and they were beyond the scope of this article. So to conclude, the risk of progression is similar between MGUS patients who are diagnosed during screening versus clinical evaluation. The MGUS detection method did not influence the predictive value of MGUS risk model incorporating a monoclonal protein isotype, concentration, as well as abnormal FLC ratio. And despite the differences in baseline comorbidities of clinical versus screened MCUS, the progression risk model derived from clinical MCUS can be applied to the screened cohort also. So I thank all the honorable faculties of Indian Myeloma Academic Group and Dr. Sumit for giving me an opportunity to present the journal article. Thank you.
Thank you, Dr. Vinodni. Thanks for a wonderful presentation. So before we quickly go on to the question answer session, so let me just quickly bring upon two more factors. First of all, I would like to welcome Dr. Vincent Rajkumar sir, who has joined us now. So as far as India is concerned, so we have total till now 91,856 people who have been screened, and the numbers that we have are somewhere closer to what we found in US. It's 1.6% above 45 years, 1.79% above 55 years of age. And the median age for the individuals with MGUS in India is around 65 years with male preponderance without any CRAP criteria. And IgG lambda are the ones which are more common. That's the thing. And there's no difference between tribal versus non-tribal as far as the Indian data is concerned. Now, as late as 1st March 2025, we did 1 year follow-up of all our patients who have been labeled as MGUS, and we didn't find a progression even in a single case out of the 62 cases that we have found to be having. So with that introduction, I would like to open the forum for discussion both with Dr. Vincent and as well as Dr. Murray. So Vincent sir, to start with you, what is the utility of this study in a day-to-day practice? Should we do screening for all? If yes, should we resort to clinical or population-based screening? And then with Dr. Murray, what is the ideal technique for screening, both in US and in the resource constrained settings? So Vincent sir, to start, if you could answer a few of these queries.
Hey, thanks so much for having me. No, we are not recommending screening. This study was just basically done to determine exactly what the hypothesis was the outcome of people who are screened different than people who are not screened. But the fact that they are similar doesn't still mean that we should be screening. So we don't recommend screening because screening requires us to show beyond that as a result of screening versus not, the screened population is doing better in some important metric, particularly survival. And so all of us are very calm about not recommending screening of the general population until the iStop-MM study finally reads out. Not the interim data that they are publishing, but really show that the screened population has better outcomes than the non-screened. The only groups that we are recommending screening for at Mayo are people with very high risk of having MGUS and MGUS related problems, and that's in our country, African Americans who already have one affected relative with myeloma. Their baseline prevalence would be 5-10, instead of 5%, it'll be 10. And then if they already have a relative with myeloma, it'll be even higher. And then there's problems with access to care. And so that's the thing. So in your screen cohort, for example, in India, if you find that there are populations where the baseline prevalence of MGUS is not 5% or 4%, but like 20%, and with whatever risk factors you find, that would be a group that you could consider, screening. In the US, the second group we are recommending screening for are people who are not African American. That'll be general population with 2 affected relatives. I guess the same thing can be done in India. If you have somebody, there are some myeloma is not familial, but there are some patients who have a close familial connection. So if you have 2 first-degree relatives in a family who have myeloma, then others in the family who are 50 or older can be considered for screening. So, but that'll be a very small, even in India with 1.3 billion people, the number of people who have 2 first-degree relatives with myeloma is going to be small. So you wouldn't really be generally screening. The purpose of screening studies that you're doing in India is mainly to find out, are there populations who are at higher risk? I initially thought that the prevalence of MGUS in India would be higher than the Olmsted County prevalence. But so far, Dr. Yanamandra has found that that's not the case. Whether it's the same in South India, in Tamil Nadu, in other populations, I'm not sure, but so far there's no specific reason to believe that there's a higher prevalence of MGUS in the Indian population, which is great. So there's no reason to embark on any major screening program or anything like that. What you have to deal with is of the people who are incidentally found to have clinical MGUS, what is the risk of progression, and is that mirroring what we find in the US? That's something to keep in mind. In the US, because the expected overall survival is so high, we are finding that most people with MGUS, even with that kind of survival, that most people with MGUS don't actually progress to a plasma cell disorder. So I don't like the terms myeloma precursor disease given to people who have MGUS because they hardly ever get myeloma. Even with an 80-year lifespan, only 10% of people with MGUS ever get myeloma. That's over a 25-year period. 90% don't. I'm afraid that in India it'll be even lower than that. That most patients with MGUS will never get myeloma, and so you don't want to alarm them. All you need to do is make sure you follow the risk stratification, whichever one you find or follow. That most people don't need a bone marrow, most people don't need annual follow-up, most people don't need bone survey. So you save your resources. Don't put your population through extra expense and interventions when they don't need, and only really do the bone marrow, bone survey, and the annual follow-up in the high-risk MGUS subset, which I have defined as anything other than low risk, but also IgM more than 1.5, not less than 1.5. And free light chain ratio, don't worry about the small ones, but only ratios above 8. That's in the in the Annals of Internal Medicine article that we published on MGUS on who needs such follow-up. And in your screen population, as you're rightly doing, you're following them, and you're going to determine, just like we did in Olmsted, what is the risk of progression, who is getting the progression, and really tailor your baseline workup as well as your annual workup to that subset of the population. Hope that helps.
Thank you, sir. So can I invite Dr. Murray to talk about the ideal techniques for screening and his comments about the latest ASH deliberations, wherein there are some study groups which talk about 40% of the population having IgM MGUS. So Dr. Murray, your opinions on the ideal techniques for screening, please.
Yeah, I think that's a great question, and thanks for inviting me, by the way, and I really enjoyed the presentation. I think, in terms of what we did at Mayo Clinic, bringing mass spectrometry into the lab, it's certainly not needed for screening. I would say that one of the benefits that we've seen in mass spectrometry, though, in the screening world is, I think, not so much the sensitivity. The sensitivity may be a downside. As you said, some people are looking at these really low level, especially IgM proteins, of which, we have studies that we did even with IFE that it's rare for these really low IgM pair proteins to progress to disease. I think for screening for myeloma, the Olmsted County study was done really screening with SPEP. SPEP's, in terms of myeloma, is certainly adequate to screen, especially in a resource-limited environment. Although I will put in a plug for the work that was done in India on the MALDI-TOF method, which really didn't use any immunopurification, just precipitated the serum into acetonitrile. I think that would be a very low cost way to screen for an M protein. Now, it won't give you the isotype, but it'll give you a screen. And I think that would be a very low cost way if you wanted to use something that was low cost. That form of the mass spectrometry, I think, would be very much cost effective. But in terms of just the normal techniques, SPEP is certainly good enough to screen for myeloma. I don't know what the free light chain cost. The free light chain cost is pretty expensive even in the US. But that's between those two, you'd certainly pick up all the cases of multiple myeloma. One thing I will say about the MALDI-TOF method is that I've come to appreciate its specificity more than sensitivity. Even though when we did a screening population, we saw, an increase in the number of detected MUGUS patients. But when we ran it clinically, meaning we were comparing it to what we were calling by gel electrophoresis, we really only saw a 1% increase in the positive samples. Because one of the things the mass spectrometer can also do is rule out maybe what we would say, a call of a band that was maybe not really real. So I think the specificity of the MALDI-TOF method is definitely a plus for us in the lab. But with that said, I'd still say for screening SPEP and free light chains would be enough for myeloma.
Sir, I would like to ask you one more question here. So, has there been any studies on the Olmsted County population which were initially screened by SPEP and wherein you run the same samples for mass fix? And was there any difference in the prevalence or difference in the outcomes for the biobank samples from the Olmsted using mass fix?
So when we looked at the SPEP positives, 100% of those will be positive on our MALDI-TOF method. So we're limited. The differences were in the very low level. And in the low levels, they were even lower in terms of risk of progression than what we classified typically as the low risk. So there are a few, but it's very low risk. So I wouldn't say there's a difference in the outcome of those patients because those were part of the study that you presented. And so there wasn't an outcome difference. Now, if you're looking for things like amyloid or some of these monoclonal gammopathies of clinical significance, and there, the detection really can make the diagnosis because as a few of the hematologists point out, if we call it negative, they rule out all the idea of a plasma cell disorder. So I think that's probably where the MALDI-TOF has its best use is in these low-level monoclonal gammopathies of clinical significance. And the IgMs are also interesting. IgMs, in terms of their distribution, clonal distribution, are drastically different than IgG and IgM, or IgA, sorry. I've come to appreciate that, the kappa lambda ratios of patients even without a monoclonal gammopathy can really be dramatic in IgM. And I think it's one of the reasons I think IgM is overcalled in the lab is because some of this can be totally IgM lambda, so to speak, and but it's totally polyclonal, and so a lot of those get called as monoclonal because you see more of a restriction of the M in the lambda band, and so I think the IgMs we really need to be careful with these, and we did a study by IFE and showed that of the really low level IgM paraproteins that we detected, we hadn't had a single progression at the time we did the study to any disease. So I really put caution into these low-level IgMs. And a lot of times clinically, when I'm in the lab, I will ignore some of these low-level IgMs because I know they don't progress, especially if the patient's in their 70s and 80s. I really don't think they're worth following.
Thank you, Dr. Murray, for answering that. I think Dr. Pankaj sir has a question. Pankaj sir, over to you.
Yeah, thank you so much, Dr. Murray and Dr. Vincent, for joining us. One of my question is that when we are doing a population-based screening, then how do we answer a question, and whether population-based screening can answer that question is that why some patients develop an MBAN and why some patients what are the reasons that which leads to the development of M-band in some people, I would say. So can the population screening can answer that question, or you think that is more of a clinical question? In the clinic, it would be answered. Dr. Vincent or Dr. Murray, if you can answer that.
Well, I'll go ahead first
Go
before
ahead.
Vincent, but my thought is that this is a scientific question, not a clinical question. So I caution you even when you read our papers on mass spectrometry, when I'm doing research studies, I call differently than I do when I'm in the clinic. So, you see these numbers of 5%, or 10%, depending on how we're doing it. These are calling every single clone that I see because we really want to understand the very question that you answered. But in the clinical arena, we don't read that way at all. I factor in age, I factor in other comorbidities. What the question really is: does the patient have amyloid? Does they not? So there's a lot of that goes into the clinical determination for me when I'm reading these things.
So thanks, David. So I'll just go through this. This nice slide has a list of questions here. So the utility of the study in day-to-day practice. I think in case you do a screening study like Dr. Yanamandra has done, we would assume that the clinical course of those patients is similar to what is clinically detected MGUS in India. So I don't think the study really influences anything in day-to-day practice for you. Should we do screening at all? Don't do screening. Never ever test for M proteins unless you have a real reason. Why are you testing for the M protein? Are you testing because you're suspecting myeloma? Are you testing because you're suspecting amyloid? Are you suspecting some real plasma cell related disorder? Don't just think about monoclonal gammopathy of clinical significance, renal significance. What you have to do is millions of people will have an abnormal creatinine, but 99% of the time, the clinical picture is not something that an MGUS will cause. You would think of a renal significance only if you're dealing with a nephrotic syndrome that is unexplained or a glomerular nephritis that is unexplained, which is different than a creatinine that's high from who knows what. That's not when you suspect MGRS. You don't suspect MGRS, you suspect proliferative glomerular nephritis with the immunoglobulin deposits. Does the patient have that kind of clinical picture? Do you suspect amyloid causing nephrotic syndrome? So don't screen for MGUS. Check for an MGUS or an M protein in patients you suspect as having myeloma, amyloid, Waldenstrom's, one of the clearly defined syndromes that are associated with the MGUS. And if you by chance find another reason for those abnormalities that you were working up, then what is left behind is called MGUS. That's the ideal way to practice. You shouldn't be ordering M protein tests whenever you think somebody has unexplained fatigue or anemia or SED rate or something. You just need a specific reason why you're ordering. The only group, like I said, that we will actually screen for until the iStop-MM study reads out are patients who have 2 or 3 family members who have myeloma and you're worried that they have some familial thing going on. Otherwise, don't screen. And so don't resort to population-based screening in India or in America or anywhere else. The ideal technique for screening, by screening, I hope you mean the ideal test for looking for M protein when you're suspecting a plasma cell disorder, I think is mass spec, if you can pull it off, because mass spec is far more efficient. And if you do it right, your labs will find it easier to do and the spikes will be easier to follow in legit patients. If you do it randomly, mass spec can cause chaos in India because you have a large population and you may read an M protein in too many people, and then your hematology clinics will be full of MGUS possible MGRS rather than real myeloma. So ideal technique is mass spec, but when you do the mass spec, who you do the mass spec test on is really should be driven by what are you really looking for. If it's not myeloma amyloid, if there's no clinical reason to suspect myeloma amyloid or one of the specific syndromes that I mentioned, then don't screen for it.
Thank you. Thank you, sir, for clarifying that. With that, I would go on to the next part of the day, the general scan, which is again something related to monoclonal gammopathies. This is of thrombotic significance. So, but before
Uday,
that, we would like to...
can I just comment something before that?
Yes, sir, please, sir, please.
No, I just want to thank the doctor who presented the discussion and did such a great literature review of all of the relevant studies. So, congratulations.
That's Dr. Vinodini. She did her DM from JIPMER and she's currently working as an associate professor at AIIMS BB Nagar, Hyderabad.
Wonderful. Congratulations.
A very promising hematologist. So as we talk, we are actually going ahead with this population study only to answer whether our prevalence is different from the other parts of the world or not. This is not to prove that we want to do screening, as Dr. Vincent has just mentioned. So as of now, as of today, we have started in Kargil district and we are going to start in the next 2 weeks with Dr. Karan Sood in the Wardha district. So we are doing in different parts of the country just to understand, is there any specific populations which are different? And hopefully by this year, September, we will be covering 2 lakh populations, 1 lakh already done, another 1 lakh to be done. So we are planning to finish this. And also simultaneously, all the patients who are positive, they are being followed up and taken care by Image. Thanks to both the past president, Dr. Pankaj, and the current president, Dr. Velu, for helping us out on that. And we are also simultaneously, thanks to Dr. Murray, and he helping us with the protocols for the mass spectrometry. We are trying to actually, for all the samples which are stored with us, for all these patients, for screened individuals, whether positive or negative, we are running mass spec with the modified protocol just to see, without immunopurification, just to see whether our results match or not. So we are doing that simultaneously. And if that comes true, and we are also using a technique of using filter paper rather than taking actual samples. So if that works through, then it makes it easier for the future monitoring of our individuals. So that's being done simultaneously. With that, we proceed on to the next part of the Journal Club or this month's webinar series. So we had, as Myeloma Awareness Month, we had a MD-DNB quiz, which was held on 24th of March, wherein 41 participants across the country participated in this. And we had top 5 individuals on the Kahoot. This was held by Dr. Nitin Yashas from Bangalore and Dr. Ankur Ahuja from Pune. And of these top 5, the top 3 individuals, so these are the top 3 individuals. So the first prize was won by Dr. Vaibhav Agarwal, the second by Dr. Akansha Agarwal, and the third by Dr. Himakshi Kinara. So congratulations for winning. This was Dr. Nitin, along with Dr. Gurpreet Kaur from Pune and Dr. Revant from Bangalore. And these are the top 5 people who came upon in the prelims. And we had a nail-biting finish, wherein we had a tiebreaker or a super over for the first prize. And the first prize was won by Dr. V. Sai Kiran. He is a DM Medical Oncology, third-year resident from Nizam Institute of Medical Sciences, Hyderabad. The second prize was won by Dr. Vinu Balram, DM Hematopath from AIIMS, New Delhi. And the third prize was won by DM Medical Oncology resident, third-year resident from JIPMER, Pondicherry. Again, you will be getting your prizes and the certificates signed by Dr. Velu Nair in this coming week. So heartiest congratulations to all the winners. One event which is still pending is the undergraduate myeloma quiz, wherein we want the undergraduates to understand the basic tenets of multiple myeloma and the plasma cell dyscrasias. This due on this Sunday, we are going to have the prelims, and Monday we are going to have the finals. We have till now 96 colleges. This is a team event. We are registering colleges. So 96 medical colleges have registered till now for this particular event. So with this, I would like to also invite you all to participate on 29th of March, wherein Dr. Hari Menon sir is doing a conference at St. John's Medical College, Bangalore, organized by him in association with Image, wherein we are going to have updates on Waldenstrom macroglobulinemia. So this is another event which we are co-hosting along with International Waldenstrom Myeloma Federation Foundation and the Caregivers Society. So this is on 29th of March, when we have got Dr. Pankaj and Dr. Velu Nair sir giving the keynote addresses. With this, I hand over the stage back to Dr. Sumit for running the journal scan, and followed by to Dr. Karan Sood for running the quiz for this week. Over to Dr. Sumit Mir, please.
Hello, sir. Am I audible?
Yeah, please.
I hope my screen is visible, sir.
Yes, sir.
Thank you, Uday, sir. And that was a very nice Journal Club discussion. And in all honesty, I wish it would have never ended. Coming to the Eagle Eye competition for this month, the the Journal Scan article chosen was VITT like monoclonal gammopathy of thrombotic significance, published in NEJM last month. COVID taught us that there is an entity called VITT with the vaccines. And today we know, few years later, there are multiple VITT-like disorders, and one of them is monoclonal gammopathy of thrombotic significance. So coming to the process for those who are new to this, the process of Eagle Eye competition is a recently published article is chosen. We invite a commentary of 175 words before a due date and deadline to us. Anyone, irrespective of designation, with interest in plasma dysplasias can submit the commentary, and the best commentary will be awarded, wherein they will be able to get an opportunity to present the journal scan along with a certificate and the lifetime membership of Indian Myeloma Academy Group. The intent is that all students as well as faculty should read the latest articles of plasma cell dysplasias, learn the art of critical appraisal, refine the art of scanning an article. This will encourage more letter to editors from our country, and at the same time give the student an opportunity to present in front of an august audience. This will at the same time generate some inter-institutional competition. There are multiple variables on the basis of which this is analyzed: the summary, the title, the abstract representation, author's core assumptions. Most important is to stick to the critical word count of 175 words. Some errors which may be over and underemphasized. Coming to the approaches and research methods, also concentrate on the methodology and statistics, which are at times underestimated. And with that, we come to a final score. So before I announce the name of the winner, a special mention for Dr. Nishant Sinha, who had a close competition. He's currently working as a fellow at AIIMS New Delhi. The winner for this time is Dr. Adarsh Patil. He is just completed his MD medicine from AIIMS Nagpur. And to the best of my knowledge, he's an aspiring hematologist and oncologist and is preparing for the entrance exams. So I request Neerav to play the recorded commentary.
Good evening to one and all. First of all, I would really like to thank the Indian Myeloma Academic Group for giving me this opportunity to present this journal scan. Today's journal is WIT-like monoclonal gammopathy of thrombotic significance. It was recently published on 12th of February 25 by Wang et al. In NEJM. As an outset, what do we know so far about the anti-PF4 related thrombotic disorders? I've just enumerated this in a table as an introduction. The trigger for thrombosis is heparin and adenovirus in the case of HIT and WIT respectively, and M protein is presumed in this proposed WIT MGTS entity. While the duration of the HIT and WIT remains transient, WIT-like MGTS has a chronic propensity for thrombosis. And if we talk about the therapeutic implications, we still do not know what works for MGTS. The story starts with an index case in the year 2022 in Hematologica Journal. It was published, anti-PF4 antibodies mimic WIT antibodies in an unvaccinated patient with monoclonal gammopathy. In our case, we have the patient number 1. He was a 60-year-old male who developed unprovoked arterial thrombosis in lower limbs along with pulmonary embolism. And over the next 3 years, despite being on therapeutic anticoagulation, he experienced multiple thrombotic events, including hepatic vein thrombosis, DVT, and recurrent bilateral pulmonary embolism. Further workup revealed heparin-independent platelet activating anti-PF4 antibodies with WIT-like properties and IgG-kappa M protein. Initially, the patient was managed with IVIG, which led to improvement. However, treatment was later shifted to ibrutinib, which resulted in correction of elevated D-dimer levels and no further thrombotic events over the next 10 months. Moving to the second case, he was a 46-year-old male who initially presented with unprovoked DVT of the right lower limb. After discontinuation of apixaban, DVT recurred. Despite therapeutic anticoagulation, experienced recurrent DVTs, adrenal hemorrhage with adrenal failure, and eventually developed severe thrombocytopenia and succumbed to CVST. Postmortem testing detected an IgG lambda M protein. Patient 3 was a 35-year-old male, initially presented with MI, DVT, and pulmonary embolism. And over the span of 18 years, he developed stroke, intrastent thrombosis, LV thrombus, mesenteric vein thrombus, and Heraldine thrombotic complications. Despite anticoagulation, IVIG, rituximab, and plasma exchange with thrombosis even persisted. And finally, treatment with bortezomib, cyclophosphamide, daratumumab prevented further episodes. Patient 4, she was a 47-year-old female who developed recurrent pulmonary embolism, DVT, CVSTs, and renal vein thrombosis with progressive thrombocytopenia with a nadir of 30,000. And in this case, despite IVIG plasma exchange and even plasma cell-directed therapy with bortezomib, daratu, and dexamethasone, anti-PF4 antibodies were persistently detected. The addition of ibrutinib led to a rapid platelet increase, and no further thrombosis was further detected. So in a nutshell, all these patients had monoclonal IgG paraproteins, which is very important because even a faint paraprotein band of less than 0.1, say, may have a major clinical significance if it is indicative of a highly pathogenic anti-PF4 antibodies. 3 of these 5 patients were under 50 years of age. All of them had thrombocytopenia, including superficial and deep venous thrombosis. All of them experienced life-threatening thrombosis at some point of time. And laboratory and molecular analysis of these antibodies was done by mass spectrometry, ELISA, and chemoluminescence immunoassay methods, which also possibly indicated that the inherent nature of these antibodies to act for a chronic and a persistent period would be due to a different binding epitope site on the platelets. But do we end over here? There's still a long way to go. Assays for detecting VID-like antibodies, which target only the anti-PF4, is not routinely available, especially in India, which limits its diagnostic utility. We still do not know the heterogeneity of the findings. Why only some MGUS patients develop thrombosis, and why only some of them respond to IVIG and ibrutinib, while others do not? This still remains unknown. In our case, patient 4 did not even respond to plasma cell-directed therapy, but only responded to ibrutinib. With this comes the question that are we really overlooking the Bruton tyrosine kinase? Since BTK inhibition affects platelets and causes bleeding, does BTK also have a role in thrombosis? The study is based on a cohort of only 5 patients to validate the findings, which is limited. Key questions still remain: which patients with unexplained thrombosis should undergo M protein assessment? Should they be monitored for progression to myeloma? It could be interesting to find any surrogate marker to identify these patients early and possibly begin a preemptive treatment and prevent a life-threatening embolism, just as we do in the case of TTP. Many stories still waiting to unfold. Thank you.
Generally, sorry, Sumit. Yeah, 1 second. So generally, we don't take questions or comments after the journal scan. But Vincent, sir, any comments on this article published in NEJM and anything that you would like to add here?
Yeah. Excellent. Whoever did the recording, I'm not sure if he's listening to it, but I'm telling you that this is something that worries me more, not for the reasons that were mentioned, that, MGUS causes VITT-like problem, but I'm just worried about the innumerable patients in whom we can make a mistaken diagnosis. MGUS is highly prevalent, right? And people also get blood clots a lot. So it's very easy to confuse that somebody with MGUS and a history of venous thrombosis and thrombocytopenia, or what looks like thrombotic thrombocytopenia, the MGUS is what's causing it. Even if you find PF4 antibodies, you cannot be sure that the PF4 antibody is actually monoclonal. If you look at this case study series, as well as the ones in the previous few issues of the New England Journal that were done from the Mayo Clinic, Dr. Anand Padmanabhan at Mayo is the one who initially characterized this MGTS phenomenon. In all these patients, we were able to show that whatever the PF4 antibody is actually the monoclonal antibody. That kind of testing is needed to make 1 + 1 is equal to 2. Otherwise, you will be calling a lot of people as having a monoclonal protein related problem when the monoclonal protein is an innocent, coincidental finding. And you will also engage in treatments that may be more harmful to the patient. The second point is, it's possible that sometimes there are false positives. These are very new assays. And if they say we found that the PF4 antibody was monoclonal, but I gave daratumumab and the patient did not get better, I have to worry more about whether they had the right assay, given that it's a new one, than whether daratumumab works or not. So I wouldn't go that far. The third thing to remember is that drugs that we use to treat myeloma will work not only when the MGUS is causing the problem, but any autoimmune disease, polyclonal. It'll work in lupus-induced thrombocytopenia and thrombosis. It'll work in people who have, we are using it like daratumumab and bortezomib for patients who have antiphospholipid antibody syndrome, and they're getting their because we are basically the most powerful people who can suppress the immune system. We have the best treatments. We have drugs that actually eradicate plasma cells. So just because something gets better with daratumumab or daratumumab, bortezomib, or something like that, doesn't mean that we've got a MGUS-related problem. It just means that we have powerful drugs like steroids, in other words, that we can make anything look better. But we have to be really, really careful about what we cause X causes Y. That's the most important story in this thing. The second point I want to make today is like for people to be really careful when they throw around terms like MGTS, MGRS, MGCS, and all that. Unfortunately, we cannot reverse this trend because it's there and like thousands of people are writing about it. But just for the people on the audience to understand that these terms are like book chapters. They tell you that an M protein may cause a problem. It doesn't mean that the M protein is the problem or what. It doesn't even tell you the name of the disease. So when you say MGTS, it's a syndrome where the monoclonal antibody is actually the cause of a particular clinical phenomenon. And you have a way of diagnosing it specifically without making a wrong diagnosis. It doesn't mean the iStop-MM study where they found a higher risk of venous thrombosis in people who have MGUS, and so have other studies. But that's like a disease association. That's not MGTS. MGTS here refers to a VITT-like syndrome that is caused by an antibody that's a monoclonal antibody that the patient has, acting like an anti-PF4 and producing the same syndrome that a COVID vaccine does. So we have to be very clear what we refer to. In MGRS, for example, the term MGRS refers only to certain specific syndromes: AL amyloidosis, light chain deposition disease, proliferative GN with immunoglobulin deposits, C3GN that's caused by a M spike, not every renal problem that a patient with MGUS has. And if you're not clear about how PGN-MID presents, how C3GN presents, how AL amyloidosis presents, or light chain deposition disease presents, you'll be suspecting MGRS in people just because their creatinine is high and they have an M protein. I won't even think of that unless the syndrome clinically fits what I know is an M protein that causes. And then you do the workup, which requires a kidney biopsy to prove that, in histopathology, that it's the MGUS that's causing the problem. Until then, you should only say it could be MGRS, it could be something, but you really don't have the reason. And when you have the reason, then you can intervene. Hope that makes sense.
Thank you. Thank you, sir. Yeah, Dr. Smith, please. I think we can get on with the quiz.
So nice to hear some practical pearls of wisdom. So just before we go to the quiz, for the next month, 24th of April 2025, the Journal Club article Sustained Bone Marrow and Imaging MRD Negativity for 3 years drives discontinuation of maintenance post-transplant in myeloma. This is a recently published article from the Greek myeloma group. And coming to the journal SCAN article for next month, a recently published article from the Japanese group, which says the soluble BCMA for disease monitoring in oligosecretory, non-secretory, flushed multiple myeloma. So over to Dr. Karan for the quiz. Thank you.
Hi, good evening. Thank you for having me. And I would like to first thank Dr. Uday Dr. Pankaj and Dr. Sumit. And I will also like to thank Dr. Vincent, Dr. Murray, because I'm in such august company. So without any further ado, we'll move on to the first question. So according to Busram et al., which MGUS subtype showed significantly higher progression risk when detected through screening rather than clinical evaluation? Option A, IgG MGUS. Option B, IgA MGUS. Option C, IgM MGUS. Or option D, light chain MGUS. All right, moving to next question. In the study by Visram et al. Again, which of the following factors was not significantly associated with increased MGUS progression risk? Option A, abnormal FLC ratio. Option B, M protein concentrations more than equal to 1.5 grams per deciliter. Option C, IgG isotype, and option D, presence of immunoparesis. So moving on to the next article. So what conclusion did Wang et al. Reach regarding the immunopathogenesis of VITT-like MGTS? Option A, VITT-like MGTS arises from polyclonal immune responses. Option B, VITT-like MGTS is associated with transient immune responses to vaccination. Option C, VITT-like MGTS is linked to monoclonal antibodies directed against PF4. Option D, VITT-like MGTS occurs only in patients with multiple myeloma. Moving on to question 4, in the report by Wang, which of the following is not true for VITT-like monoclonal gammopathy of thrombotic significance? Option A, chronic prothrombotic state with intermittent thrombocytopenia. Option B, BTK inhibitors have been found to be effective. Option C, recurrent thrombosis despite therapeutic anticoagulation, which DOACs and or vitamin K antagonists. Option D leads to venous thrombotic events, and arterial thrombosis has not been described. Last question is from trivia. In 1844, the first recorded case of multiple myeloma was reported in a patient named Thomas Alexander McBean. What unusual symptom led to the discovery of his disease? Severe bone pain, excessive protein in urine that solidified when heated, multiple pathological fractures, persistent fatigue. So in the meanwhile, we have the quiz results. We can quickly discuss the answers. For question number 1, the answer is IgA MGUS. IgA MGUS has notably higher progression risk when detected through screening, with a hazard risk of 4.3 versus clinical detection rate, where the hazard risk is 1.3. This suggests that biological factors such as higher rates of FLC abnormalities in screened IgA MGUS cases might drive the difference. Next question. In the second question, the answer is IgG isotype. So in here, an abnormal FLC ratio, M protein concentrations more than 1.5 grams per deciliter, and immunoparesis were associated with higher risk of progression. However, IgG isotype alone was not predictive of an increased risk. Next question. Question number 3, the answer is VITT-like MGTS is linked to monoclonal antibody directed against PF4. So the monoclonal plasma cells produce a PF4 binding antibodies, and this distinguishes it from the classical VITT, which is associated with polyclonal antibody responses following vaccination or viral infection. question number 4, please. The answer to this question is it leads to venous thromboembolic events and arterial thrombosis, which has not been described. So it is actually described. So the answer is D. Next question. So interestingly, the answer to this question lies where Thomas Alexander McBain, who was a patient in London, presented with fatigue and bone pain. However, the key finding was when he brought his urine, which solidified when it was heated. It was an early indication of what was later identified as Bence-Jones proteins. And it was William McIntyre who noted this finding and passed on to Henry Bence-Jones, who identified this unusual protein. With this, I'd like to thank you, and thank you everyone for giving me the opportunity.
So, Nirav, do we have the question?
Yes,
The
yes.
results?
Dr. Abhinash Kota from Nizam Institute of Medical Science, Hyderabad, sir.
Nizam Institute of Medical Sciences?
Hyderabad. Dr.
wonderful.
Abhinash Kota.
So, heartiest congratulations for winning the quiz. So, as we are already running late from our schedule, I would request General Velu Nair sir to kindly thank our August experts who joined us for the day, Dr. Murray and Dr. Vincent, and give your final comments, please.
Yeah, lovely to see my friend Dr. Vincent here, and we really enjoyed your excellent comments as usual. And I must thank Image for having put this together, and such an important topic, so easily misunderstood, and especially associations and what we ultimately end up chasing on the clinical side. So I like to firstly congratulate Dr. Vinodni for having done an excellent job in presentation, and Colonel Uday for having moderated, and Dr. Vincent and Dr. Murray to have actually interacted and actually throw light on, the associations and thereof, what to chase and what to not chase, and not to go the wrong way. So I think that was so important, because very often we end up doing that. And Dr. Karan Sood for having conducted the quiz so well. And I think that was very well covered. And for Dr. Nirav and Sumit to have actually coordinated the whole show. So I'd like to thank Image for having continued this excellent activity. And I also would like to congratulate the winners. And you know what? MD students are doing better than DM students, which is such a great sign. So, there was a time when, hematology was lurking in the backbenches and there were no takers. Today, I'm seeing MBBS and MD students outdoing DM students. You don't know how happy it makes us. And to see that student who actually, did a great job on the thrombotic article, he wasn't just an MD student. So, the future looks bright. And as long as, we have, people like Vincent and teams and people from the US and other parts actually encouraging us and, guiding us, I think we have a good, bright future. Thank you very much, and lovely being here. Thank you. Jai Hind.
So thank you, sir. So with that, I would like to thank Dr. Murray, sir, for sparing his time early in the morning at Rochester, and Dr. Vincent for joining us at this hour of the day there. So thanks to both of you. Thank you, the current and the past president, for joining us. And we have total 107 attendees as of now who are still present on the screen as of now. So thanks to one and all, and Jai Hind.
Excellent. Thank you.
With permission of Velu, sir, can I stop the,
Yeah.
close the session?
Good night.